Hey everyone, welcome back to the channel. I'm so glad you're here because today we are diving into one of my absolute favorite topics in all of clinical pharmacology, the drugs we use to treat heart failure. I'm Professor Shebu Orichabello, and over the next few slides I'm going to walk you through the entire treatment landscape, the guideline, directed pillars, the secondary agents, and yes, the memory aids that are going to make all of this stick, whether you're a medical student cramming for exams or a practicing clinician brushing up. This one is for you. So grab a coffee, hit that subscribe button, and let's get straight into it. Alright, before we touch a single drug, we have to talk about classification, because how we classify heart failure literally decides what we prescribe. Stick with me, this is the foundation for everything. Here's the big idea: we split patients by ejection fraction. If is 40% or below, that's your reduced group, and that's where the full 4-pillar regimen gives the biggest mortality punch. HFMEF sits in that mildly reduced 41 to 49 band, and HPF is preserved 50% and above. Then we describe severity two ways: the ACC-AH stages A through D, which is the structural journey, NYHA class 1 through 4, which is how the patient actually feels. Keep both in your back pocket. And here's the line I want you to tattoo on your brain: guideline-directed therapy modifies the disease, it doesn't just move fluid around. That distinction is everything, and it's exactly where we're heading next. Okay, this is the slide, the money slide, the 4 pillars of AFA-IF therapy. If you remember nothing else from this whole lecture, remember these 4: ABAS, ARNI, beta blocker, aldosterone antagonist, and SGLT2 inhibitor. Say it with me: ABAS. Each one hits the failing heart from a completely different angle: neurohormonal blockade, sympathetic blockade, antifibrotic action, and that brilliant cardio-renal SGLT2 benefit. Now here's the pearl that trips people up: you start ALL4 early at low dose and titrate up over weeks. Low doses of all 4 absolutely beat maximum doses of just 1 or 2. That's not my opinion, that's the evidence. And check this out together: they prevent roughly 1 death for every 4 patients treated over 2 years. 1 in 4, that is a staggering number in medicine. Let's break each pillar down, starting right now. Pillar number 1, neurohormonal blockade. This is where we shut down the renin-angiotensin-aldosterone system, and honestly it's where the magic begins. Our first line superstar is the ARNI, sacubitril valsartan. It's a 2-for-1. The neprilysin inhibitor boosts your protective natriuretic peptides, while the ARB blocks angiotensin 2. If ARNI isn't available, you drop back to an ACE inhibitor: enalapril, ramipril, lisinopril, or an ARB if they can't tolerate the cough. But listen carefully to the safety story. Watch for hypertension, hyperkalemia, and falling renal function. Monitor that potassium and creatinine. Angioedema is higher with ARNI. And please, a 36-hour washout between AC and ARNI. And never combine an AC with ARB. And now the fun part, our first mnemonic: Taptopia L for the side effects of ACE inhibitors: cough, angioedema, proteinuria, taste changes, orthostatic hypotension, pregnancy contraindication, renal impairment, increased potassium, and leukopenia. Run through it a couple of times, it's exam gold. Pillar 2, sympathetic blockade, the beta blockers. Now here's what fires me up about this class. They take chronic catecholamine toxicity, that constant adrenaline hammering on the heart, and they shut it down, driving real reverse remodeling. But you cannot use just any beta blocker. Only 3 are proven in H-E, F-bisoprolol, carvedilol, and metoprolol succinate, the extended release one. Nebivolol is an extra evidence-based option. Memorize those names. Golden rule: start low, go slow. Only begin once the patient is euvolemic and compensated, and never stop them abruptly. Watch for bradycardia, fatigue, hypotension, bronchospasm, and remember they can mask hypoglycemia. And here's your mnemonic for when to be cautious: A, B, C, D, E. Asthma block meaning heart block, COPPD. Diabetes because it masks the lows, and E for decompensated or unstable heart failure. Simple. Simply, and it'll save you in a viva. Pillar 3, aldosterone blockade, the mineralocorticoid receptor antagonists. And I want you to pay attention here, because this class hides a really elegant secret. Spironolactone and iplerenone block aldosterone at its receptor, cutting sodium and water retention AND, limiting that nasty myocardial fibrosis. Spironolactone is non-selective. Iplerenone is selective with far less gynecomastia, so if your patient develops breast tenderness, switch them over. Safety, and I cannot stress this enough, hyperkalemia is the big one. Check potassium and renal function before you start and after every dose change. Avoid it if potassium is above 5 or if the eGFR is low. Here's the clinical pearl I love. MRAs are the ONE diuretic type class that actually reduces mortality. Why? Because their benefit is neurohormonal and antifibrotic. It's not just about losing fluid. That's why they sit in the foundational regimen, not the add-on group. Beautiful pharmacology. Pillar 4, and this is the newest kid on the block, the SGLT2 inhibitors, or as I like to call them, the gliflozins, tipagliflozin and empagliflozin. These drugs genuinely wrote the guidelines. They block the sodium glucose cotransporter 2 in the proximal tubule, giving you glycosuria natriuresis and osmotic diuresis, plus this whole cascade of cardio, renal and metabolic goodness. And here's the jaw dropper: the benefit is completely deep anti of diabetes. You don't need to be diabetic to benefit, and it works right across the ejection fraction spectrum, A3, HFMF and HPF. Practical tips: watch for genital and urinary infections, mild volume depletion, and that rare euglycemic decay. So teach your sick day rulers, hold it during acute illness, fasting or surgery. Best part: barely touches blood pressure or potassium, so it's an absolute breeze to add on top of the other pillars. Now let's talk symptom control diuretics. Here's the mindset shift I need you to make. Diuretics make patients feel better, but they don't make them live longer. Hold that thought. Your workhorses are the loop diuretics, furosemide, torsemide, bumetanide. They block the sodium-potassium 2 chloride transporter in the thick ascending and give you that in the potent diuresis for pulmonary and peripheral congestion. Titrate to the lowest dose that keeps them euvolemic. When loops aren't enough, you bring in thiazides, hydrochlorothiazide, chlorothalidone, or metolazone for resistance. Combine a thiazide with a loop and you get sequential nephron blockade, incredibly powerful, but watch those electrolytes like a hawk. Monitoring hypokalemia, hyponatremia, hypomagnesemia, renal function, and volume status. Teach your patients daily weights so they can flex their dosing. Remember, diuretics complement the 4 pillars. They never replace them. So what happens when we've optimized the pillars and symptoms as TILL persist? That's when we reach for our secondary and add-on therapies, and there are some really clever tools here. Ivermectin blocks the funny channel in the SA node. Yes, it's actually called the funny current. It slows the heart rate without touching contractility. Perfect for patients in sinus rhythm with a heart rate of 70 or more despite a maxed out beta blocker. Vericiguat is a soluble guanylate cyclase stimulator. It boosts CGMP and vasodilates, and it shines in worsening heart failure after a recent decompensation. Then hydralazine plus isosorbide dinitrate, a balanced vasodilator pair, especially valuable in self-identified black patients and when ACI or ARB just aren't tolerated. And finally, digoxin, our classic anotrope and rate control agent. It cuts hospitalizations but not mortality, and it has a narrow therapeutic window, so watch for nausea, visual halos, and arrhythmias. Okay, deep breath, because now we hit the emergency. Acute pulmonary edema. Your patient is drowning in their own fluid, and you need a plan that snaps into action. That plan spells LMOP. L is Lasix for furosemide to offload that fluid fast. M is morphine, an occasional adjunct for severe distress, and use it cautiously. N is nitrates venodilation to /preload, but avoid it if they're hypotensive. O is oxygen, target those saturations and get non-invasive ventilation CPAP or BPIP on early and flash pulmonary edema. And P is position, sit them bolt upright to ease the work of breathing. One crucial caveat that examiners love: do not stop chronic beta blocker unless they're hypotensive or in cardiogenic shock, because abrupt withdrawal makes things worse. And always hunt down the trigger: ischemia, arrhythmia, non-adherence, or infection. Treat the cause, not just the fluid. Right, this is my favorite slide: revision aids. All are mnemonics in one glorious place. Screenshot this one. Seriously, put it on your wall. Have as the 4 chronic pillars: ARNI, beta blocker, aldosterone antagonist, SGLT2 inhibitor. Then your broad heart failure overview: beta blockers, ARB, RN, nitrates, diuretics, aldosterone antagonists, ivermectin and inotropes, and digoxin. Immunopope for acute pulmonary edema, Lasix, morphine, nitrates, oxygen position, thiopyral for those ACE inhibitor side effects, and DIG fast for acute decompensation care. Say them out loud, quiz your study buddy, write them from memory. These little acronyms are the difference between fumbling and flying in your exams and on the ward. Trust me on this one. And that brings us home the key takeaways. If this video helped, smash that like button. But before you go, Let's look in the big ideas. Number 1, 4 pillars started ARY. Combine an ARNI or ARB, a beta blocker, an MRA and an SGLT2 inhibitor. Initiate low, titrate to target within weeks. And remember, partial doses of every pillar beat full doses of just 1 or 2, saving about 1 life for every 4 patients over 2 years. Number 2, diuretics, EASE, pillars modify. Loops and thiazides control congestion and symptoms, but they don't improve survival on their own. And number 3, monitor and individualize. Track potassium, renal function, blood pressure, and heart rate, and tailor the secondary agents to your patient. Always follow current guidelines and treat the person in front of you. Thank you so much for watching. I'll see you in the next one.